Formal presentation of today is about the importance of research, and we're very lucky to have my colleagues Tom Pinkney, who's a consultant colorectal surgeon and professor of surgery in Birmingham, and Neil Smart, who's also a consultant colorectal surgeon and associate professor and also a trustee of IA. I think you've heard earlier today from David Jane how vital research is to the development of healthcare services generally. And I think what you're about to hear is the kind of work that IA has been supporting progress in those areas. And hopefully Neil and Tom can give you an insight into what progress we've been making. Neil, thank you.
Thank you all very much for the kind invitation to talk to you today and to talk about some of the things that have been happening in the world of research and also how IA has been involved in that. Can I have the first slide, please? That's there. Sorry, so I have to put this disclaimer up because I'm going to show you some data from one of the studies that I've been involved in. And the title of the talk about the importance of research, which is on your programme, could have a number of alternatives. This could be one of them, about its importance to you, to the organisation, and to us as clinicians who look after patients with ileostomies. It could also be retitled why you should be involved in research and why this organisation should be involved in research, because we as clinicians and those of us who are actively engaged in research can't do it without you as patients. And also it could be, I suppose, this about how patients have helped us who are cold-faced clinical researchers do our research better. And of course, this is me 30 years ago when I had less grey hair and was about 30 kilograms lighter. That was before I got involved in research. So, what are you laughing at? I mean, anyway. So, I think this is the thing that we have to put out there, and it is that better care starts with research. And there is an absolute plethora of evidence about its importance. If you have people and organisations and hospitals that don't engage, you have people still doing the same thing that they did 20, 30, 40, 50 years ago. And that's not a good place to be. I think I do very little now that is exactly the same as when I graduated in 2001. So why do you need to be involved? You need to be involved because it's better for you, because you get the benefits from it. It's better for others with your condition, so there's that altruistic element. But it also is better for everyone. It's better for the NHS, for all of your hospital. That old phrase about a rising tide lifts all boats is really important. And how can you make a difference as patients and as an organisation? You can change and you can influence what research gets done, about how it's carried out, and how the results are conveyed into the public sphere and they're applied in everyday practice. There are now standards that are mandated by the United Kingdom about how patients and the public are engaged with research. So it is no longer this lip service that we used to see, say, 20, 30 years ago. We have to have dedicated systems and processes and governance for making sure that patients are listened to and implemented when it comes to research. There was a really important statement that was made in the last presentation, and that is, despite all the knowledge that I as a health professional can have, it's not the same as having the lived experience. And if you don't get that input, you can get things very badly wrong. And I'll touch on that in a little bit more later. So IA has had a lot of work done over the past 12 to 18 months about trying to develop dedicated strategy for research and how it engages. And lots of time has been spent on committee meetings and trying to get this right. And we have one of the slides up there which just teases out a few points which I think are important to emphasise, saying that IA wants to continue to develop our research portfolio. It's been a great supporter of research for many years, and it wants to continue to be so, but it wants to be broader, deepen the knowledge of bowel disease across a wider range of points in the patient journey. And how are we going to do it? Well, part of it is us as a research committee, providing that expert guidance. We've got to make sure that when we have projects that are under our umbrella, that they are monitored and delivered and reported appropriately, and that those results are disseminated widely so that you can then get them implemented into patient care. Any healthcare professional who is involved in bowel disease has to recognise that stomas are the common ground of all bowel disease conditions. And it doesn't matter whether your interest is in cancer or inflammatory bowel disease or pelvic floor or trauma or whatever, a stoma remains one of the key fundamental treatments that you as a surgeon have to offer a patient to both save life and improve quality of life for many. And I put the quote from Del Roberts at the bottom there where she highlights, it's not a curse, it is a cure, it is life. And I think it's really important that we remember that. I've touched on before about the things that can go wrong when you don't involve patients. So my own particular area of interest and research is in parastomal hernia. And I'm going to demonstrate here what happens when you don't get it right. So the great and the good from the hernia community got together about 11, 12 years ago and decided that they were going to have a discussion about trying to define what the problem is and then how they could do things better. And some of the surgeons involved are very good friends of mine, but what I think that they've done wrong here is that all the people on this paper, and who've come up with a definition of what a parastomal hernia is, there's not a single stoma care nurse there, and they've not engaged a single patient at all. And yet these people are very gifted surgeons. They have operated on many patients with parastomal hernias, and they know the anatomy, the physiology, and all the other things, but they still haven't engaged. And they've said what a parastomal hernia is. They importantly tell us what they think a parastomal hernia isn't, saying it's not a problem when you have the stomal lymph folding under the skin into the subdermal fat to give you a siphon loop or a bulge. And this is what happens when you put someone else there who's more patient-orientated and perhaps a patient advocate. And when you ask a dedicated stoma nurse to get involved, you get a very different answer, where they say, well, yeah, you can separate out those two entities, but it's relatively meaningless from the patient perspective because they get exactly the same symptoms, the same degree of bother, and they look down and there's still a massive bulge on their abdominal wall. So the semantics of teasing it apart is relatively pointless from the patient perspective. Focus on the things that matter. And the same group, again, led by a stoma care nurse, and the lead researcher on this project was a stoma care nurse, went and did something really important. They went and looked at the quality of life with patients who had problems with bulging around their stoma. And they came out with something really interesting. If you have a bulge, your quality of life is worse than if you don't. If you had your stoma formed for benign disease rather than cancer, your quality of life tends to be worse. If you've got an ileostomy rather than a colostomy and you get parastomal bulging, your quality of life is worse. And if you've got a bulge which is particularly large, greater than 10 centimetres, your quality of life is worse. Really important for us to know. Particularly because there's only one thing that's really been researched in a lot of detail when it comes to looking at how surgeons actually make stomas, and that is the use of mesh to try and prevent these bulges or hernias from happening. Now, there's lots of arguments amongst surgeons about this when you say, is it something we should be doing or not? The European group said absolutely, definitely yes. The Brits said maybe, it's okay evidence. And Cochrane, who are the arbiter of all things high quality research, sort of, came along and went, no, it's a load of rubbish, don't do it. So you can't even get the experts to agree, which is always a great place to be, isn't it? But the question might be asked, well, why have all these eminent people ended up disagreeing with one another? Well, the first question I think you should ask is, well, are the patients representative of everyone who has a stoma in these studies? And the answer is, of course, no. Because when you go looking at who has been included, the first thing you find is that the patients they included were almost all planned elective surgery. The vast majority, more than 90%, had end colostomies formed. And it was almost always for cancer and very rarely for any other condition. So you've got a very particular subset. Then we say, and what were they measuring? Well, they were measuring the things that were important to surgeons. Can I feel a lump? Can I see it on a CT scan? And the questions that might matter to patients like, well, is this safe to do? Are there any problems? Are there complications? What happens to my quality of life? Almost never measured, because they didn't bother to ask patients for almost all of those studies. Not a single one of them had patients engaged with them in the design and planning and conduct and reporting. So when I was tasked by NIHR with running this study, and I'm really grateful that Tom's here today because Tom was instrumental in helping me get this up and running, was we wanted to look at something different about patients, about how stomas were made and then how it impacted in terms of their quality of life and the development of hernias. And I presented here back in 2016 as the Brian Brook Lecture what was the plan for the CIPHER study, and I'm going to share some of the data today with you as to what's happened many years later. Well, the first thing to say is that our recruitment was going absolutely fantastic until our old friend COVID came along and kind of upset the apple cart. We had 80 centres that were recruiting, and we were doing really well, just about on target, and then you can see on the curve where COVID hits and sends us off target. But that, well, we had about 2,500 patients in the end. It's not bad, and it's close to where we wanted to be, but there's a nice little trick we had up our sleeve because it's an observational study rather than a randomized controlled trial. And that is that you can just take the same group of people and follow them up for longer, because what matters is how long people are exposed to risk or how long they've had the actual condition of interest for. So we went to NIHR and said, can we have some more money, please? And they went, it's so important, this question. The answer is, of course, yes. And they gave us another $250,000. So that's great. And we finished our follow-up in September of last year, and we're doing the analysis as we speak. So what have we found? Well, what we found, first of all, is that there are 3 broad cohorts of people who get stomas. And yes, patients who have cancer are an important cohort, and they form about 3/4 of the population whom we recruited to the study. But here's the important thing. We've got, more than ever before, about 1/4 of the population who didn't have cancer, and they fall into 2 groups. They're either patients who've had stomas because of inflammatory bowel disease, almost never studied in this context before, and a really important cohort of people who've loosely got connective tissue disorders. So they're patients with things like diverticular disease and also functional gut problems, because they've had things like pelvic organ prolapse, for example. We've got nearly 700 patients combined in those 2 groups, never before studied. So going to be some really interesting data. They have very different underlying health needs. They've been exposed to different medications, and particularly for the IBD cohort, questions like how do steroids and the fancy new molecular whatever-mabs that patients with IBD get put on, how does that influence the outcomes of surgery and the development of long-term problems? So we'll capture that data for you. We've also got a completely different range of surgery than has ever been studied before, with a much broader representative population of different operations. And we've got many more stoma types. For the first time, we've got a large number of patients who've got ileostomies, over 950, who we've got data on. And nothing like this has ever been done before. So completely different. And I'm hoping that once we've finished all the analysis, I'll be able to come back and tell you how unique to you your risk factors are and how they differ from other people with different types of stomas. So the ongoing assessment of CT scans is an MD project in its own right, led by Neera Rajaratnam, and that's ongoing. What I can tell you is when you go and ask patients, have you got a parastomal hernia, what we can see is that as we go further and further away from the index operation, by the time you get to about 2 years, 40% of patients have got a parastomal hernia, and it doesn't matter whether you had your surgery for cancer or not, the rates are the same. I can also tell you that at 12 months, patients with a parastomal hernia have a much worse quality of life when you go measuring it on some of the instruments that we use. And I can also tell you that when I look backwards at that group, who I know about at 12 months, when did their quality of life start to diverge between those with and without parastomal hernias? It happens really early in their post-operative process. So something's going on by 6 weeks, which is driving differences in quality of life. And I don't know what that is yet, and I'm hoping we'll be able to tease that out. I can also tell you that prophylactic mesh use is really low, which is probably no great surprise, but there are lots of other factors that we can examine in a study like this, which will be important about what it is that happens intraoperatively and which may lead to parastomal hernia development. So far, so good, but what were the reasons behind some of the successes that we've had? Well, the first thing was thinking about what is it we're measuring. And much of the stuff focused on about patient-reported outcome measures quality of life rather than just detecting something on feeling someone's tummy or not. And the question was, well, what can we use? Well, there were some measures out there, and to be quite frank, they weren't very good because they were either very cancer-specific or they were very generic to life with having a stoma, but they didn't tease into the issues surrounding the different types of stomas or whether you had a parastomal hernia or not. Things that were better had come out, like the colostomy impact score, which is very good for detecting hernia problems, but is only validated really in colostomy patients, though watch this space, we have plans to validate it in other stoma types too. So what did we do? Well, in conjunction with Jane Blaisby's unit in Bristol, we decided to make our own patient-reported outcome measure, and we did a whole series of work with patients, stoma care nurses, as well as surgeons, looking at all the literature and doing dedicated qualitative interviews to try and make something that was unique to parastomal hernia. Design a questionnaire, get feedback from patients, and then help refine it. So where did we get to? Well, we had patients from Birmingham and Exeter and Bristol who came forward and helped us, patients with all different stoma types, and we then piloted and pre-tested the questionnaire several times. And what we had was at the end, a questionnaire that was largely constructed by the feedback from the 16 patients with stomas who gave us their vital input. So it was easy to follow, easy to fill in, and was really very much driven by something that they felt that they could easily do and send back to us when they were in follow-up. I have to say, I've got to give thanks to 2 patients in particular who really came forward and did a lot of hard work for us about helping us think about the packs that we send out to patients, not just that PROM that we developed, but the other questionnaires for quality of life and about how they're coping, and were they easy to follow, were the layouts appropriate, and 2 patients in particular, and Sue and Nick, helped us enormously get this right. And by doing that and having patients intimately involved in the design before you start conducting it, we've ended up in a situation where up to 4 years of follow-up, we've still got better than 80% data completeness. That, I think, is very impressive. So what's the next step as we go forward? Well, NIHR have been very clear that the next step is to stop just having public and patient involvement, but to go towards a concept of co-production, which is where patients come to the fore in research and where we're moving away from one being a dominant partner and one being a lesser partner, where we're getting much more towards a situation of equality, where that power sharing differential is going to be evened out, recognizing everybody's contribution. I think this is going to really be the future. So what might it look like? Well, I can tell you that IA has been right at the forefront of this concept. This is what it looks like, and I have to say it was my honour and privilege as editor-in-chief of this journal, Colorectal Disease, to be able to publish this. So this is the Papoose study, which was led by Sue and was funded by IA and the Kingston Trust as well, who are here with the stand outside today, and with other people like stoma care nurses in partnership. And it's also open access, so every single person in the room can go and download this for free and you can read it. And looking at pregnancy outcomes for patients who've got stomas. And nothing like this had ever been done before. This is an absolute first, and it really is about the mission statement that IA has about broadening and deepening our knowledge. So does it align with the strategy? It most certainly does. It's developed a portfolio with a broader interest. The research subcommittee helped identify it as one of the things to fund. We've had the whole rigorous oversight process, and I, as research subcommittee, involved with it, but was also the editor that sorted out the peer review for it to make sure that it was written to the appropriate standards, and also that it's now been disseminated open access to. IA haven't just done it once, they've been at it again, and they've funded further studies as well. Next one is going to be PROFA, which is the European Society of Coloproctology's forthcoming cohort study looking at the management of patients with parastomal hernias, whether it be operative or conservative management. And again, we're going to be looking at anyone over the age of 18. And what's really important here, again, is that we've got a patient with Sue being the co-chief investigator, with Tom Pinkney as a professor of surgery, and a broad multidisciplinary team including researchers and stoma care nurses. It's much more about an equal partnership model. And what it will enable us to do by having newer technologies that we're implementing is we'll be in a position where we can get away from the concept of researchers having to go to patients and ask for them to feed back with questionnaires, where we can now disseminate things through mobile phone technology, and patients can bypass the surgeon directly and give their feedback on their quality of life and what's important to them. So we'll get it back directly into the computer servers in Birmingham, where the REDCap database is located. What it means is that we can ask things now direct to patients, and they can send back to us things like health-related quality of life, stoma impact scores, and something called MyMop, which is Measure Yourself Medical Outcome Profile. I'll show you this in a second, as well as decision regret, about whether you feel that you've done the right thing for you. Did you make the right decision about your healthcare, or do you regret having that operation? MyMop is the questionnaire on the left-hand side, and what it does is it asks you to say, well, what is important to you as a patient? And then it asks you to rate that, and then in 12 months' time, we'll ask you to rate those same things again. So it takes your priorities as our priorities, and it takes your priority individualized to you. It's not you as a cohort, it's every single individual person access their own control and baseline. So I think it's really patient-centric, and it's going to change the way in which I think we're going to do research in the future. And I'm delighted that IA has been involved in helping fund these projects. So in summary, I think everyone benefits from research. Patients and patient organisations are absolutely key stakeholders. So please get involved. Thank you very much for your attention.
Thanks, Neil. That was, as usual, a superb exposition of the role of research, and also the valuable work that IA is doing in taking research forward, which is of direct relevance to the things that matter to you guys, actually.